Hello, and in this special episode for International Women's Day, myself, Alex Owen, academic developer, and Faye Forbes, diversity and equality apprentice, sat down with Professor Dharani Hapangama, Dr. Nicola Tempest, Dr. Manu Kaur, and Dr. Alison McLean to discuss their work at the University of Liverpool and Liverpool Women's Hospital with women who suffer from endometriosis. We discuss some of the research related to endometriosis and also their experiences of supporting women with the condition. We hope you enjoy. Wonderful. In this special podcast series for International Women's Day, I'm really pleased to be co-hosting with our guest host, Faye Forbes from the Academy. Faye's put together this series on endometriosis as it's such an important topic that many of us know little about, and yet it affects the lives of so many women. Our guests today include a number of professionals involved in supporting women with endometriosis, and we're really pleased to be speaking to you today. So thank you so much for your time, colleagues. So before we start, please could you introduce yourselves and tell us a little bit about your background?
Okay, I'm Dharani Hapangama, Professor of Gynaecology in Liverpool Women's Hospital and University of Liverpool.
So I'm Nicola. I'm one of the academic clinical lecturers here. So I've been working here quite a lot of years, and I did a PhD supervised by Dharani a couple of years ago, looking into the endometrium and endometrial stem cells. We've done lots of different work on endometriosis, looking at markers for endometriosis and different tissue types, and then looking at alternative treatments for endometriosis as well. So things that could be reused, that are used for different diseases, and looking at kind of very alternative treatments such as CBD.
My name is Manu Kaur. I am a consultant gynaecologist, and I'm working in this trust since November last year as an endometriosist. And I have acquired specialized training from different tertiary level surgical care centers for endometriosis and other excisional forms of tissues. So I would hope to give some surgical expertise.
And I'm Alison McLean, so I'm an academic clinical fellow and specialist registrar in obstetrics and gynaecology. I've worked with Professor Hapangama's team for a few years now, and I'm going to be starting some exciting research actually this year in June, which is focusing on adenomyosis, which is a condition that's similar to endometriosis, but there's not much known about it. So hopefully I can bring in a little bit of information about that for this podcast as well.
Wonderful, thank you. And Nicola, if we just come back to you, what was it specifically that drew you to this specialism in endometriosis?
So I started work here kind of a couple of years out of med school, and Prof. Hapangama was my kind of clinical tutor at the time, and because of her enthusiasm and because of her research background, she's very good at kind of enticing people in to get some research done and to get some stats and to get people recruited. So I kind of just started on that at the beginning, and then found the clinics very interesting, found the surgeries interesting, and just kind of from that, and from speaking to patients and from speaking to staff, you kind of see what different avenues to take research down. We did a study on people that were having laparoscopic sterilizations and kind of seeing if we picked up endometriosis on these patients, because obviously they weren't coming for that condition, but it was just like, how often do we see it in the general population for people that kind of aren't complaining of the condition? And then from that, we moved on to kind of some biomarker studies. And then after being in touch with very different people, and you meet different people at different conferences, they kind of take you down different lines. So we met somebody who manufactures their own tampons and owns a tampon company. And from her, she was kind of going down the line of, could we use cannabis in tampons to kind of treat endometriosis? So we're doing kind of a questionnaire study about, would people be willing to use these? Is this kind of an option? So kind of all different levels and lines, and kind of just get sucked into it, don't you? Like,
Brilliant.
On that point, if I can make a comment as well. So I think I even went to the medical school to become a researcher to find an area to research on. So I started looking into the endometrium because endometrium is very unique. It's one of the most unique organs in the human body because women menstruate and other animals generally don't. So then with that interest, when I wanted to look at a particular disease that is relevant to this menstruation process, endometrium is one of the most prominent ones because endometriosis happens because women menstruate. So that's quite interesting, but likewise, that brings its own problems because most of the research is based on using various animal models to understand a disease. So you can use mice and other rodents commonly to study the disease and then translate that knowledge into human practice. But with endometriosis, you can't do that because mice don't menstruate. So that is one of the main problems when it comes to research into the disease because it's very difficult to study it because we can't use humans as the model. So, and then as a gynecologist, when you go to the hospital, the amount of people we see in a gynae clinic with endometriosis associated symptoms is huge. So there you have to struggle almost to treat them because the available treatments are quite limited and our understanding of the disease is not complete. So then it's a good field to work on.
Am I right in saying that the research is still emerging? Why do you think it's still such an under-researched area, do you think?
It's lack of understanding in many areas because when you go to the very scientific forums, this understanding that, okay, you can't easily create endometriosis in a mouse is not fully understood by the scientists.
Sure.
So the usual research pathways, almost always having a mouse model, is expected. So even if we are trying to develop a good research proposal to attract funding, people would look at it thinking, oh, well, it doesn't even have a mouse model.
Sure.
It's not even just that, though. It's women's health in general is represented in research.
Absolutely.
And so therefore kind of moving on as a whole, endometriosis is only a proportion of women's health. Like if you think of women's health
in general, often you see like obstetrics or oncology component gets more importance than benign conditions.
So I got a diagnosis when I was 18. So compared to a lot of women, that's quite an early age to have had a diagnosis. So on average, diagnosis of endometriosis takes 8 years. What are your views on why diagnosis can take so long?
Well, one of the difficulties with endometriosis is that a lot of the symptoms feature in other medical problems as well. So a lot of them are quite non-specific. And so things like chronic pelvic pain can be caused by lots of other medical comorbidities. So it can be quite difficult to get these women into the right places to get a diagnosis. But then actually getting the diagnosis is really difficult because that involves an operation and an actual biopsy of the tissue itself.
Would you say as well that there's issues from GPs, like GPs not being trained appropriately to notice early on certain symptoms of endometriosis and making that referral?
Exactly, that was what I was going to add into it. It's about the awareness, and the awareness is not necessarily to the primary care providers like GPs or other paramedics who might hear about some problems that a girl or a young woman is facing in terms of pain, but also amongst our society, I think in general, people often don't have information about how normal menstruation cycle should be perceived. And there is a lot of taboo in certain ethnical groups, for example, so which forms a barrier to make this a very easily talkable subject, for example, or to come out with the symptoms that a girl or a female might be facing. And I think lastly, also because we don't really, maybe it's becoming more emergent now, but in the past we have struggled to have dedicated clinicians who are able to understand it and to also treat it, to manage it correctly. So there were less integrated multidisciplinary teams, for example, which were existing to lend support to this very chronic and debilitating symptomatic disease.
Yeah, I think you're right, Manu. In terms of some of the kind of informal research that we've done, very much seems to differ across various cultures in terms of how comfortable people feel talking about women's periods, in terms of generations as well. Something Faye and I've picked up from the conversations that we've been having with others is it's almost communicated to girls that, well, these are periods, periods involves pain and you just kind of have to get on with it. Do you think there's some of that?
Definitely. I think we are opening up more, and there's more and more agenda created for awareness being raised for this. And it's going to, in some countries, for example, just to name a few, Australia or Canada, there have been initiatives at the level of secondary schools, for example, to talk about this subject, which is very, very good. Globally, there is still a huge lack to promote this. I think it also needs to be guided in a correct way, that it doesn't really disseminate a lot of unnecessary concern amongst youngsters and parents.
A fine line.
Yeah, I think therefore the dialogue needs to come from people who really understand the entity very well. And that is then supported not only by clinicians, but also the research side. I think they both need to amalgamate it in terms of coming out and then taking ownership and leading it in correct pathways, because I think the danger is that you might stigmatize it in a way that a lot of women who may not have maybe necessarily the endometriosis itself, but maybe are dealing with, like Alison very correctly mentioned, chronic pelvic pain due to some other etiologies, that they might get that label, and then of course the treatment is not going to be effective enough for them, and they will be struggling in the long run and then being disadvantaged.
And the teaching and learning is great. And what you said, everybody thinks period pains are normal, but there is an element of normality.
Exactly.
That's what we need to promote. That's what people need to know. So yes, you're going to have periods. You're going to start them, between 9 and 13. It's normal for you to have a period. You might have a bit of pain, but you shouldn't be fainting. You shouldn't be passing out because you've got a really low hemoglobin. But there is an element of normality, and I think making everybody think that they should have no pain is again the wrong thing to do. It's like there's a line somewhere.
And the other thing is, as you rightly highlighted, Manu, worry about what would this diagnosis mean. So in one way, we all have the responsibility not just to diagnose. I mean, diagnosis is only one part, but to have to develop a correct pathway for the woman who's going to be stuck with the diagnosis.
Yes, exactly.
So it's not, you've got endometriosis.
So everything is attributable to that. So you need to, of course,
and especially when you say attributable to that, because we know that there's lots of conditions that totally cross over with endometriosis. So are we treating the woman's other conditions, or are we just putting everything down to endometriosis? What if they have got irritable bowel syndrome as well? What if they have got fibromyalgia as well? We need to be kind of supporting everything, not just the
and just the one focus, okay, it's a gynae condition and it should be dealt with just the gynecologist, and we are going to do one thing,
Cure the world.
and cure it. That doesn't work for this. It's a woman with symptoms, and you have to give them the full support from all avenues, so she can continue and have a fulfilling, normal life.
Yes, exactly. It's all about, quality of life to be enhanced, and that just doesn't have an effect on the patient herself, but generally on our society, socio-economical, families, the workplace, for example. But indeed, I totally agree. You need to have modality concept in terms of offering them that support. And what you were talking about earlier, for example, CBD, which is cognitive behavioral treatment and guidance, which is something is a part of that comprehensive treatment that we can offer.
It's like a package of care.
Exactly. Yeah.
Not just because I think it does have a psychological input with the how are you going to cope with the chronic pain? What are your coping mechanisms? Just as somebody of how are you going to cope with your anxieties because you can't get on an aeroplane? How are you going to cope with day-to-day life, looking after your children, going to work, doing everything
exactly.
you need to do?
Yeah. And unfortunately, also there is more and more emerging evidence that it's causing kind of cross visceral sensitizations. So the pathways which create the pain in endometriosis, for example, they don't necessarily only cause pain because the lesion is sitting in one of the reproductive organs, for example, but though they converge sometimes, and they then cause pain coming from different organs, which may not immediately have a lesion which you can visualize, which can be, for example, very often because of the gravitational, aspect of our pelvis is the bowel, for example, the colorectal site. And then indeed it really makes sense that, you can have bowel symptoms without even having objectifiable disease in the bowel, and it may not be immediately related to endometriosis, but it is somehow indirectly related to it. And I think that needs recognition, and after that, you need a team of experts to deal with it, and that will require multidisciplinary approach from psychologists and physiotherapists and general surgeons, urologists, us gynecologists, and so on and so on.
One thing that I have been involved with recently with colleagues from Oxford and London to look into the presence of mental health conditions with endometriosis in particular. So we have done some review of the available evidence, and it was quite interesting to see that there is a huge psychological burden and association with mental health conditions. Right, I mean, obviously so, with the uncertainty of the disease, how the disease is going to progress, and symptoms, etc. But likewise, there is another side to it. So people who have mental health conditions may have a higher risk of having a diagnosis as well. That's the available evidence. And on top of that, on a different note, there are some guidance coming out from the Pain Society regarding how to manage patients, particularly surgically, when they have a diagnosis of fibromyalgia, for example, because whatever treatment we provide may have different outcomes if they have fibromyalgia diagnosis. And interestingly so, a woman with a diagnosis of endometriosis are 6 times more likely to subsequently develop the diagnosis of fibromyalgia.
Wow.
So these conditions are interlinked. So we have to be aware of changes. Okay, you make a diagnosis at the age of 18, 20. We have to be aware of the influence of all these things when we carry on supporting the life cycle of the disease.
What can individuals do to kind of speed up receiving the care that they need then, whether there is a formal diagnosis or not, do you think?
I think if somebody's at the point where they're going to see their GP and they're trying to access primary care, then it's important to make sure that they communicate to their doctor the symptoms that they're having. And if those are things that might be suspicious of endometriosis or chronic pelvic pain, things like painful intercourse or heavy painful periods or bowel disturbances, then the GP can actually instigate some hormonal treatments for them in primary care, so they can access treatment quite quickly, and that is a guideline that all primary care physicians are guided by. So they can start hormonal treatments, and if that improves their symptoms, then that's great. They can have some treatment straight away, and we don't necessarily need to wait until they come to the gynae clinic.
And the other thing is non-invasive methods like an ultrasound scan. If the pelvic organs look normal on an ultrasound scan, that is quite a good reassurance. So because with severe disease, we usually see abnormalities of the ultrasound scan, distortion of the anatomy, etc. So at that point, considering the use of hormonal methods that Alison mentioned is a good thing. And unfortunately, hormonal treatments have a really bad...
They do. People just say, but I don't need contraception. And you're like, well, you're not using it for contraception. You're using this as a treatment. And I think making people aware that it's not just contraception. These are for treatments for your periods. I think a lot of us spend a lot of time talking to women and breaking down the myths about things like the Mirena coil, which we know are really, they're licensed for chronic pelvic pain and they're really good for treating that pain. But there's a bit of a cultural myth that it's awful when it's inserted, or it's going to go missing, and we're going to get pregnant, and then the baby's going to come out holding the coil. All of these things are just so rare, but it's unfortunately a lot of women talk to each other about these interesting things that might have happened once or twice in history, and then they get put off the idea of taking a really effective treatment. So
what I have noticed in my practice is that often when you break down, like indeed what you're saying, you often spend a lot of time explaining them the proper mechanism of some hormonal treatments. When you explain it to them, they often are willing to actually use it. So I think you may need to encourage our primary care providers to maybe spend a little bit more time, or maybe we as Endometriosis Society in our national level, maybe we should talk about it a little bit more and explain why it is beneficial, because it just inhibits the proliferation of the disease. So, you get like less growth of the lesions, even if they might be existing in a very mild form, for example. And we forget, or we can't really ignore the fact that a lot of women have been very well helped by just using hormonal treatment throughout their lifetime. They have never needed to undergo the risk of general anesthesia and the associated risk of undergoing a diagnostic laparoscopy, because we can't really ignore these, like Nicola very correctly mentioned.
Are there any developments in non-invasive, non-surgical ways to diagnose endometriosis?
I think people come out with lots of different tests, but I think the problem is that endometriosis is such a heterogeneous condition that I don't think there's ever going to be one-size-fits-all test. Yeah. And I think realistically, if there is going to be tests, there need to be tests that can differentiate between the different stages of endometriosis to kind of differentiate whether we need to do surgery on people or not. Because there's no point us kind of doing a test where it just tells you you've got endometriosis or not, because then if we're going to operate on everybody, we know that there's no benefit to operate on some people. So that just kind of increases operating, increases risk with no actual added benefit. So if there is going to be a diagnostic, I think it needs to be able to differentiate between different types of the disease, different stages of the disease. And that's definitely not something on the market at the moment.
I think that's going to offer a lot of challenges as well to develop such a test as well. And I think we then come back to the point where we were discussing about it's the proper understanding of the disease.
Yeah.
I think education, knowledge, awareness. It's the symptoms of the patient that you have. So in the end of the day, you need to listen to the patient. So the patient knows the best what is going on with them, and you tailor your diagnostic approach and your treatment approach depending upon what they are telling you in terms of how they are having their symptoms. And that's the only justifiable way to move forward, I think, at this point in time.
And I think this goes back to managing expectations. So if we can kind of get the message across, and for primary care to kind of manage expectations at the beginning and say that, you know, we do need to try these hormonal medications that are not just used for contraception, because we do get quite a lot of people come through that have never tried any medications, and they literally come and see us and they're like, what, so you're just saying go on the pill? And you're like, you're not just saying go on the pill, you're saying we need to have a trial of hormonal medications. It's different.
There are two points that I would want to add into that as well, which is very important. I come across that very often. Even if young girls or females are prescribed any type of pill, they might use it just for 1 month or 2 months, and then it's decided that it's not efficacious, and that's incorrect, or because of the side effects. But there are like numerous types of pills on the market, and you may need a different type of progesterone, for example, in your combined oral contraception pill to give you the right type of effect without having the side effects associated to it. So you sometimes do need to explore things before, you know, we jump into it. But having said that, that does not exclude some very young girls, if they are having horrendous pain and they are fainting, or it's causing them to stay away from school or other social activities, or the quality of life is being impacted, they should not be gaslighted and should not be ignored equally as well. So then, you know, I think it really needs reiteration that recognizing symptoms and making that differentiation between what are the symptoms, what is the phenotype of this patient who's sitting in front of me, and that goes back to us gynecologists, but also to primary care providers.
Are there any possible explanations about what causes endometriosis? For example, is it genetic, or is it something you're born with, or do you develop it once you get to that mature age?
I think the main need is menstruation, but additional causes could be a variety of things, because as we have previously heard, endometriosis is a very heterogeneous disease. So I think the etiology for each of those different subtypes might be quite different. But we know there is some familial relevance. So if mother, sisters, and everyone has it, there is
in a very limited group of women. I think they have looked into it specifically, and I think it's about some genetic component, but it's unclear.
It's multifactorial, just like diabetes. But other things like environmental pollutants and various other things have been proposed, but I think we are still trying to understand it rather than being very clear. But menstruation has to happen.
Yeah, I think menstruation is indeed the key component, what is thought to be the underlying cause. But again, the concept of retrograde menstruation is valid, but that happens in a lot of women, and not every woman has that capacity to develop endometriosis. So you need something on the cellular level to cause that adhesion in the pelvis of those cells, which then are capable to survive. You know, normally in our normal immune system, we have mechanisms which have the potency to kill anything which is abnormal, should not be there. For example, you know, then we're talking about the macrophages, their phagocytic activity, and the natural killer cell and things like that. And also, then we can't really forget about a very limited number of women who have endometriosis which are not in the pelvis, which could be in the thorax, for example, or the diaphragm. So that really cannot necessarily be attributable to the retrograde concept of menstruation, and you may need to think about lymphatic spread or maybe vascular spread, or but I think we need more research into this.
Wonderful. Thank you, colleagues. That's been such an interesting conversation. So this podcast is called the Developing Practice Podcast. And we love to end each recording just with a few kind of take-home tips that listeners could reflect on in terms of their own personal practice. So if you wanted to leave our listeners with a few thoughts in terms of maybe how they could support their colleagues with this condition or raise awareness, what would they be? So maybe if you gave us one or two each, that would be great.
I think we need to promote health education, and I think that's one of the biggest things, because I think there's a fine line between having periods and having endometriosis, and I think we shouldn't be pathologizing periods, but we should make sure that people that do have pathology have the correct treatment. And I think educating people from a young age and potential what are normals and not normals could help.
I would add into this that we should also invest time, effort, and money into developing multidisciplinary teams. So that is really, really important for these women if you want to give them a complete, comprehensive treatment. And that does not really limit to having just a pain clinic or a colorectal surgeon with you or a urologist with you, but it's more than that. It just needs to be converged together so that all the clinicians are on one line.
Like when you have an oncology clinic and you
Exactly.
have the oncologist, the dietitian,
Yes.
the surgeon, the Macmillan nurse, the pharmacist, you have everybody there, and you don't have to see everybody every time you come, but you
have the possibility to reach those people when you need them.
Yeah.
I would actually add to that, that not only within the clinical teams, but the researchers should work together as well. So we have this continuum with the patient, working with the patient, understanding the disease and feeding back, and to have that ongoing dynamic conversation in the clinical care as well as in research. So we get somewhere rather than picking one point and then expanding on that part. That's why
it's feedback. It's kind of like interaction between the researchers and the
instead
clinicians.
of competing, you need to work like synergistically, don't you?
Yes.
Like, kind of get to an end point.
I would agree as well. I think education and awareness is key to helping women with this condition and with the clinical side and the research side. And then on that note, I suppose something that I think is also something that needs more awareness is adenomyosis, which we have talked about here. And I think it's brilliant that we're having this podcast and we're talking about endometriosis. And I think of the women's health conditions, that's probably the one that's more in vogue at the moment, which is brilliant. I think we also need to talk about adenomyosis, which nobody really knows much about. So just as an example, it's a condition that we think affects 1 in 10 women of reproductive age. And of those women, it probably causes infertility, recurrent miscarriages, pregnancy problems, and to a quarter of them, as well as pain, heavy bleeding, horrible
and there's a big crossover as well with endometriosis.
Yeah, but most people haven't even heard of it, so therefore there isn't that much research funding in the area. There isn't that much awareness with primary care clinicians or patients themselves. So I think maybe it would be good in a year's time we could come back and have a podcast about adenomyosis as well. Yeah. Try and raise awareness about that, and helping the women who really have minimal treatments. The main one is just a hysterectomy, which is not great for most young women who want to have children, obviously.
Yeah.
I found it useful to hear about endometriosis from a medical point of view and listening to the challenges faced from medical professionals in terms of diagnosing, treating and managing the condition so many women suffer from. I also really enjoyed hearing about the difficulties in researching endometriosis and the theories around what could cause the condition.
Yeah, absolutely. They certainly shared so much around some of their work to do with endometriosis, which I'm going to take away and think about. I really enjoyed hearing from our colleagues also in terms of how they support women with the condition. We've heard through the series of podcasts that the average diagnosis time is about 8 years for the 1.5 million women with the condition. And I really appreciated what our colleagues were saying about the importance of a kind of multidisciplinary approach to ensure that the appropriate support is in place for women with the condition. Well, if you'd like to take your thinking further, we've added some resources to the website on a specific podcast reading list, which you can access at liverpool.ac.uk/the-academy/podcast. So do check those out. We also love to hear back from you about each episode, so please do tweet us at LiveUniAcademy, and you can also find the usual podcast hosts at eLearnerMatt or at Alexandra_Owen on Twitter.
If you've been affected by any of the issues raised in this podcast and would be interested in joining an endometriosis support group, please email us at equality@live.ac.uk.
Great. And we really are grateful for those of you who've taken the time to either rate or review our show in your podcast provider's app. It really does help others find us. Or alternatively, we'd really appreciate it if you could recommend the podcast to your colleagues. Bye for now.